Thank you so much for joining us today for our webinar. Today we'll be talking about contracting for value-based care. We'll just go over a few housekeeping items briefly. The webinar will run about 30 minutes, and then we'll have about 15 minutes of Q&A. So if you have any questions, we can answer them at that time. All participants will be muted during the webinar, so if you have a question, you can use the chat function. To submit a question for the Q&A session, you can use the Q&A box in the bottom of your Zoom control panel. There's a red arrow pointing to that Q&A function right there. So just enter your question in there, and it'll be entered into our queue for us to answer the question for you. And just to let you know, the presentation will be emailed to all participants this afternoon, so watch for that email in your inbox. And it'll also include a link to a survey, so if you could take the survey and just let us know how we did today, we would greatly appreciate it. And we hope you'll join us for our next monthly webinar. So you decided to enter MSSP risk-based contracts, now what, on June 4th at 11:30 a.m. Central Time. We are Lumina Health Partners. We're your partner on the journey to value. We are recognized industry leaders to assist healthcare providers in optimizing their strategic direction, financial outcomes, operating performance, and cultural change. These are some of our advisory services: value-based strategy, digital innovation and analytics, clinical transformation, and leadership and governance. And today our webinar falls under value-based strategy. Today we are so grateful to be talking with Kathy Nazarian from Rush Health, and also Marty Manning, who's principal at Lumina Health Partners. Thank you so much for joining us, and I'll hand it over to Marty to begin our presentation.
Okay, thank you, Lisa, and welcome everyone. Good morning to most of you. Good early afternoon to the rest of you. Kathy and I are pleased to be here. Clearly, this is a pretty broad subject. We could probably do at least a whole day symposium on it, but we only have a half hour for our formal remarks. So we thought that we would cover some basic things. First of all, what do we mean when we say value-based care? It's a pretty widely used term, and so we wanted to set the scope for that. And then when we talk about contracting for it, what kinds of contracts are we talking about? We'll be focused primarily on contracts with payer organizations, but as you'll see in a moment, there are some other important types of contracts that need to exist to make your network effective. And with regard to the payer contracting, we've chosen 6 areas to focus on, and these were kind of culled from our experience. So I've done some years of consulting with this. I was the president of Advocate Physician Partners for about 8 years, and Kathy, my co-presenter, has a vast amount of experience as well with Rush Health. So we think that between us, there's a lot of war stories and lessons learned and tips and things like that to be told. And we look forward to sharing that with you, and then too during the question and answers if you have anything more specific than we get to. Before we do get into that, just a little disclaimer. First of all, we are not providing legal advice here, and in particular, we're not advising you on whether the program that you've put together or the network that you have assembled meets the tests of clinical integration that would allow an organization to proceed with joint contracting on behalf of private practice physicians. You need to work with your attorneys on that. Secondly, I would just say every contract and negotiating situation is unique. So we want to be clear, we're not assuming any liability for your application or non-application of the things that we talk about here. But our goal is simply to give you some, like I said, some tips and some experiences that we have had based on working literally with dozens of payers and contracts between us. And specifically, we are not encouraging anyone to deal or not deal with a payer, because that's a concern in the world of antitrust. So with that, I will move on to Kathy to talk a little bit about, when we talk about value-based care, just exactly what are we referring to?
Great, thank you, Marty. Good afternoon, everybody. We are pleased to come and talk to you about this. This is what I would call a brave new world, value-based care. Some providers have been under forms of this for many years, come and gone. I would say for most providers, though, this is a new area. We've been really living in a fee-for-service world for the last 20 years. So value-based care, the first thing I say to our providers is it really does sit on top of traditional fee-for-service. I think moving entirely to systems such as the 80s when it was capitation, that's an alarming thing to signal to your providers. So the key thing that most of the arrangements that many of us providers are doing with payers really is the foundation is fee-for-service revenue. and then we put the value-based piece on top of it. And I think you can look at the value, the phrase out there that everybody talks about is the value-based part comes because it's now based on the value of the services you're getting, not on the volume referring to the fee for service. The more you bill, the more you get paid. So we look at it really, it's called the triple aim around the country, but the real goal of the value part is improving the quality and the outcomes while reducing the total medical cost. And we do expect that value-based care is here to stay now. It's going to continue to grow, and we do expect that this is going to start being a substantial part of business for most of our providers on top of their fee-for-service revenue. And as far as the market perspective, Medicare has moved into this over the last 10 years. We all know about the Medicare Shared Savings Programs. They have a lot of other demonstration products, the oncology care model, bundled payments. They've just now launched some new primary care programs, direct contracting, other things which are continuing to shift providers into more risk-based contracts where providers are responsible for the cost of care. As we know, commercial payers follow Medicare. So in this day and age, most Medicare payers, most commercial payers now have different types of accountable care arrangements, ACO arrangements, shared savings arrangements. And what we're really finding is the commercial payers want to transfer the risk to providers and move to narrow, high-performing networks. And this is some statistics. This was a survey that was done in the United States last year, talking about kind of the progression of payment from the three categories. The blue color is really your fee-for-service revenue. The orange is a combination of fee-for-service and pay-for-performance. And then the yellow is really what we're talking about when we're saying moving into value-based care. That's your population health, where it's going to have some aspects of risk. And really what this is projecting is that they are expecting in the next couple of years that the population health, the value-based reimbursement is going to move to 50% of the reimbursement for providers from a national level. I will speak for Brush Health. We are now edging at about 35% and expect to be probably closer to 40% in another year or two. So we do think these projections are definitely, you know, what we're seeing here in the Chicago market. And now we're going to turn it back over to Marty, and he's going to discuss some more aspects of contracting.
Sure, thank you, Kathy. So when I talk about value-based care organizations, I think of it as kind of the three-legged stool of bringing together a network of providers, going to the market to obtain managed lives, so I'll use that phrase in quotes, and then supporting a program through a set of infrastructure systems and processes. And contracts are really the glue that holds all of that together. So it's not just the contract with the payers, although that's obviously an important part of that, but it's also the things that bind the network together in what ways and forms. But all of this contracting should be done pursuant to some sort of a broader strategy for your organization, which should include things like, what is the targeted number of managed lives? What's the risk tolerance that the organization has over time? Because presumably one's risk tolerance will increase over time as the organization becomes more competent at managing that risk. What forms or types of contracts would the organization enter into? Who are our preferred partners? So who are the member physicians? Then who are some of the other strategic partners, providers in the community, facilities in the community with whom it is necessary to work in order to have success at the programs? And then any sort of tiering of the network. So sometimes you talk about the Marines and the Army. So the Marines are the highly trained elite corps that can go in and initiate some contracts where there is high performance expectations and a disciplined approach, and facility at change management is required. And then that can be broadened out to a more full part of the network later on. And then specific contracts are entered into pursuant to that overarching strategy. I'm going to walk through this is dialogues we have with our physicians on a daily basis. Why do providers need to shift to value-based care? Why should they shift to value-based care? And I've kind of rolled this up into 5 key areas. One of the key things that I'm frankly excited about, I've been working with insurance companies for 25 years, and I would never call it a partnership or collaboration. I think this is finally an opportunity for providers and payers to work together and generate some more meaningful relationships and a win situation for everybody involved, including the employer and the patient. I also think it's about product growth. As I was talking about earlier, the payers are looking to do high-performing narrow networks,
And if we don't start working with payers under value-based arrangements, we're simply not going to be in a position to be asked to participate in any type of narrow network product. So this gets you a seat at the table to start showing payers how you're able to perform under a risk-based contract, and you're able to hit the triple aim with the quality, outcomes, and cost. It's also, I think, a glide path to risk. Most national insurance companies, most local insurance companies that we work with are willing to work with providers. They understand why capitation was not successful in the 80s and 90s. They want to help ease providers back into this type of value-based risk. So a lot of them are willing to do a glide path to get providers on the right path. And one of the biggest reasons I'm very excited about these arrangements is the access to data. It's an enormous amount of data we are able to get partnering with insurance companies about our population of patients. You get very robust claims information, other clinical information, so that we can really manage the population of patients. And least of all, but not less important than the others, is this really is going to be an opportunity to either enhance your reimbursement through shared savings opportunities or preserve reimbursement, because the payers are coming in strong to ratchet down fee-for-service pricing. So value-based care is the arena that we all need to be successful on to maintain or maximize our revenue.
So what kinds of contracts are we talking about? I think often when we talk about value-based care, we think about the payer contracts, but there are a couple of other really important ones. Those are the contract that binds member providers, whether that's physicians or physicians and mid-level providers or other entities that you might put together into your network. And they are typically bound by something called a provider participation agreement, or PPA, and then also a business associate agreement. These are very, very important documents to work on, because among other things, they create the foundation by which the data sharing that Kathy alluded to can occur pursuant to HIPAA and other considerations. So you have to have your paperwork in order, the proper relationships documented with all of the providers that you're going to roster with the payer to enable some of that data sharing. And I'll talk a little bit more about that later. But in terms of other strategic partners, they might not be members of your networks, but you may want to form more close working relationships with some sort of a preferred status for referrals, because they do a better job or they meet data reporting requirements or participate in protocols with you. So when we're talking about these contracts, you know, this is the typical list. It includes both commercial and governmental, and really it's any sort of a relationship that goes beyond traditional fee-for-service. And one important one that I didn't mention here, but very important for organizations that are coming together, newly formed, and trying to build a critical mass of managed lives, is especially for health systems, is their own employee health plan, their insurance plan, their beneficiaries of that plan. That's, in a certain way, the ultimate full risk contract, because the system pays for every claim in it. And so anything that can be done to manage costs and improve outcomes directly benefits the sponsor of the program, and in fact also has some other benefits like absenteeism and presenteeism management as well. So these are the typical kinds of contracts that we're thinking about. For a little bit of the Rush Health experience, turn it back to Kathy.
Sure, yes. Lumina today asked me to kind of let you know what we're experiencing sitting in the shoes of the provider. And I've kind of highlighted some key areas of what we found just while we're negotiating. And then at the end, we'll talk about what that looks like after you're moving into implementation stage. So the key difference, I think, from traditional fee-for-service contracting is you need a team of people in your organization. It can't just be your traditional contractors such as Marty and ourselves. You need clinical people, you need analytical people, you need IT support. So you really got to build what we call a VBC work group to manage the contract negotiations and the implementation and the future success under those arrangements. You have to have strong abilities in the financial risk modeling area. Marty will walk through some key provisions in a few minutes that we'll talk about this further. And the language review is key. Besides negotiating the right financial risk terms, there's so many critical items in the language, and I think Marty and I had a hard time picking out which ones to talk about, but today we're going to pick 6 of them to really give you more feedback on. The quality measures are always a gateway in these programs. If you don't hit the quality, even if you hit the cost, you're not going to get the shared savings. So So you have to have your clinical leadership actively engaged. And then the data is key. Getting the right data inbound to your organization from the payers, and then the data going outbound where you want to supplement the data the payers have, their claims data with our EMR data is all very critical to the future success. And then moving forward, moving into the next arena on this, we go into the contract protections. And these are some things that Marty will go into more detail, but just to give you at a high level, a key thing when you're negotiating is to have an exit clause. Have the ability at some point, if things go south, to get out of the arrangement. Do not get yourself locked into a new risk-based arrangement that runs, 5 to 7 years. Have an out clause. Have financial reconciliation rights. I'm going to leave that for Marty to talk about, but you need to have the ability to have a third-party actuary audit. Another key thing is managing your risk. You can have some very high-cost patients. You need to have a stop loss, a threshold. We call that a member cap, where you're not responsible for the spend of a high-cost patient after a certain threshold. Another key thing that we try to do is negotiate material change. Your population of patients that are attributed to you, the types of services you provide, that could change over the life of a value-based arrangement, and it could cause detrimental consequences to your cost targets, to your risk terms. So you want to have some kind of clause that if something changes in that future relationship that you're managing the risk, you have the ability to renegotiate. And then you really got to dig in with the payers and negotiate a standard reporting package with deliverables and time frames. Otherwise, you're not going to have the data you need to manage your population of patients. And now Marty's going to dig into this a little further on the 6 key areas.
Yeah. So Kathy and I went back and forth and said, if we had to pick just a handful of things that are unique to so-called value-based care contracts, what would they be? And after some going back and forth, we came up with this list, and you may have others, and if you do and have questions about them, we'll be happy to address that in the question and answer session that follows. But just kind of going through the flow of this, the first step is how are patients assigned to you through attribution or some other form? How are those patients normalized through various risk adjustment processes, and where do they plug into various calculations? What are you supposed to do with these patients that are assigned to you? So what quality measures, what cost targets, cost measures are there? What kinds of information will you have to be able to manage them? Because as Kathy mentioned, if you don't have data, you really can't manage beyond the fee-for-service world level of care management. How will you be rewarded or punished for your performance? Because when you get into downside risk contracts, there are actual punishments or penalties, or you're writing a check back to somebody at some point. And then lastly, what steps can you take to help make sure that you get a fair shake at this? Because a lot of the scoring is done by somebody else, and it's sometimes a black box. So what can you do to add some transparency to an otherwise opaque kind of a situation? So we'll just go through these quickly. You will be getting a copy of these slides, so I'm not going to read all of the bullet points to you, but just a couple of comments. When we talk about attribution, I'm using that in the broadest sense of the word. Is how are patients attached or assigned or attributed to the organization? And it really seems like there are 2 approaches payers have. Some are very conservative and have fairly tight definitions, so they qualify the types of historical contacts that would have been made and how far back those contacts goes in order for them to be relevant. But other situations, they're much more loose. So the one payer situation I was aware of, they wanted to attribute 100% of the patients in the market. So literally, there was a situation that arose where a patient 15 years ago had a lab test at a freestanding lab that the health system subsequently purchased. And that payer, wanting to attribute 100%, thought that there was enough glue there to somehow assign that. So you need to understand how the attribution methodology works. I think as the market is maturing on some of these shared savings contracts, provider organizations have less ability to negotiate the model because payers will say, we need to be consistent and fair to everybody in the market and consistent in what we explain to our employer customers that we're selling policies to. So if you're a market taker, you at least need to have full knowledge of what you're getting into, and then seek protections, especially as the models of attribution get more loose. So just some general comments on that. And then The next area was this whole area of risk adjustment. First question is, how will risk be adjusted? Are they using a proprietary system like Verisk or somebody else? And then, or is it a proprietary model? And who actually does the risk adjustment? Is it that the payer has licensed the product and uses it themselves, or is it actually run at a true arm's length level? And then importantly too, how is the result of that risk scoring used? So I was exposed to one situation where even though the payer said, we're going to use this third-party software system, they're going to run the data, it turned out they wanted to limit the amount of risk adjustment that could occur. So even if the risk score came back and said there was a 5% increase in risk, they wanted to cap it at 2%, not necessarily arbitrarily and capriciously, but they were concerned that the organization might game the risk scoring through some coding initiative and wanted to protect themselves from that. So the concern was legitimate, but if you didn't actually have that spelled out for you, they could just say, we're using Verisk or whatever risk scoring, and okay, that's fine. So one of the things I would recommend here is that you have added to the contract exhibits that detail the exact math of how the calculation will be done on the upside and the downside, and a couple of different examples. So you're not negotiating the methodology, you're just clarifying it again so you fully understand what's going on in the processing of the data, and there are no surprises later on that wouldn't withstand some sort of a dispute resolution process. So it's kind of like in fee-for-service contracting, it's like you need to learn how to be paranoid with these new areas or terms and structures of these things. Now, the next point is about making sure, to the extent reasonably possible, you have congruence across the measures, because you will be entering into more than one contract. So, for example, many payers are concerned about, focused on, and have measures around management of diabetics, but they all do it a little bit differently. So you want to make sure that you fully understand how standard they are. Are they using the HEDIS definitions? What are their criteria for inclusions and exclusions? And importantly, how does that compare with the other contracts that you have? So can your systems model it appropriately? One thing that some organizations have done is to say, okay, so everybody's measuring diabetic care differently. Why don't we get our doctors together and talk about what's an ideal model of diabetic care management? And if we do that right, we'll do well on all of these other disparate ways of measuring and unique one-off kinds of approaches and processes. So there's an opportunity to make some lemonade out of the lemons that you might not otherwise be handed by the market. But it's key that you can model the way that they measure you, that you can replicate that in your own systems, so that there aren't surprises later on with that. And with data sharing, Kathy made this point earlier, and I did as well when talking about the PPA and the BAA in particular. You talk about data sharing, but you want to make sure that the payer explicitly acknowledges that the arrangement that you have will allow the kind of data sharing you would all like to have occur once the contract goes live. So one of the things you might do is, for example, put a copy of the PPA, the provider agreement, and the BAA as exhibits to the contract, and have them warrant that, yes, this meets our test. So we're not going to come back at you in 6 months and say, oh, this doesn't meet HIPAA qualifications. In a lot of contracts, there is a section called the severability. So if any part of this contract is deemed to be unlawful or violate some regulations or whatever, the rest of the contract remains in full force. It's important to say, well, if for some reason it's subsequently determined that this data sharing is not allowed under HIPAA, that voids the entire contract or the risk sharing portions of it, because what you don't want to have happen is they get a new guy in the legal department or the internal audit or compliance department, and they say, oh, no, these are all bad, and the data spigot shuts off, but you're still stuck with downside risk. You want to make sure that you kind of line up that your risk with these contract kinds of protections. Other things to say about data, I've worked on contracts where there is actually a penalty for a payer who failed to provide the data. And one of my favorite little things to do in negotiating. You say, well, if you don't have any intention of not providing the data, then you shouldn't object to giving a term that says we'll pay you a per business day fine if we don't get it to you. And not just get you the data, but get it in an agreed upon format. So for example, having an exhibit that says this is exactly how the data will be presented, how often it will be presented, and if they change formats or have errors in the data or delete certain records or omit certain records, they're subject to these kinds of penalty provisions. So I'm mindful of the time, so I'm not going to go through all of these. In fact, I will skip to the audit rights because you'll get these slides and you can look at these. But the only thing I'd say about this is make sure that there are also exhibits in the contract that lay out how the calculations of shared savings or losses are calculated, both upside and downside, because if you read the language, it could be pages long and your mind can just spin by the time you read it. So having a simple table that just shows you the plus and minus and times and multiplication division will really save a lot of confusion and disgruntlement later on. And then the last area I would talk about is these appeal rights. So again, typically the scoring of these is done by the payer, so you want to try wherever possible to have the right to have data sent to a third-party auditor that you can mutually agree upon that allows them to review this thoroughly. And if the payer is delayed in getting the information to the third party that they need to do that work, then that extends any deadlines that you had for review. So if you had 30 days to review that, well, that starts when the third party says we have clean and complete data, and then you can move forward with that. Okay, so those were our top 6. I'd be curious to hear from in the comments or questions section whether there are any other areas of importance or concern with these. Back to Kathy.
Yeah, so we're going to kind of wrap up with one last slide, and then we really are interested and excited to have a dialogue and hear your questions and thoughts on this brave new world. The contract implementation, after all that work on the front end to negotiate the risk terms, the language terms, is implementing the contract, and is really key to focus on a lot of areas. It's very different from a fee-for-service contract where you sign it, you give your providers the rates, and everybody moves on. You really have a whole lot of stuff that you have to operationalize. There's key requirements that you have to get to the payers. There's deliverables on both ends. A key thing is setting up the governance structure. You want to have a joint operating committee with the payer so that you can have regular forums to review the data, to review the population that you're managing. How can we improve? What do we need to work on? And then internally, you need to have a structure put in place to work with your providers. We've set up kind of neighborhood networks with our providers and their home hospital in their home area, and then we work with them and have local medical directors so that we really can get all of our physicians engaged to work with their population. The data, it's a heavy lift from your IT department, but there's a lot of work to get that data in. After we work so hard to negotiate access to this very valuable data from the payers, you have to have ways to get that data in an efficient manner and then be able to deliver that data to your clinicians to use it as actionable data. And then you also have to establish the feedback to the payers because there's always requirements of supplemental data that the payers are looking for from providers' EHRs. The communication and education cannot go unsaid. Those are the most important areas. You've got to be able to communicate to your providers, to your hospitals, to everybody involved. What is this contract? What are the nuts and bolts of it? How are we supposed to work together on this? And then have regular education, because they will need to hear it many times to understand how this works. This is very different, much more complicated than fee-for-service. So you need to have forums for your clinicians to be able to interact with the people that are managing this from your contract team, your clinical and analytics. And then there's obviously a lot of work on the peer delivery so that you can get the quality and the outcomes and the efficiency and the cost. Many things you've got to work on there. And then the data is key, but once you have the data, if you don't know how to use the data or analyze it, it's not going to do you any good. So you really need to get robust analytics in place so that you are actually able to develop different reports and meaningful information. Our medical director says it every day to our analytics person, I need actionable data. I need you to tell me what the data says and how this is going to help me give better care to my patients and help us be more efficient in the healthcare delivery. So all of them are very key areas to work on, but it takes time, and it takes time to develop the right team of people. So we know that this was just giving you kind of a little bit of feedback on all these areas. There's a lot more that Marty and I can go into on all these things, but we kind of want to pause now. This is our deck. We want to open the floor up now to questions and are happy to dialogue, sympathize, answer anything that we can.
Thanks, Kathy and Marty. Appreciate all these valuable insights. So just to review some of our housekeeping items, if you'd like to ask a question, please submit it using the Q&A box in the Zoom control panel. You can see that red arrow is pointing to it right here on your screen. We're happy to take any questions right now for the next 15 minutes. Marty and Kathy would be happy to provide additional insight. So if you have any questions, go ahead and enter them now and we'll begin answering them. All right, so how do you get physicians engaged in value-based care when most revenue still comes from fee-for-service?
I get that question all the time. I think physician engagement is key, and I think the first thing that comes to everybody's mind is obvious, but it's harder to do than you think, and that's an incentive program. Physicians respond very well to data and information, and if that gets tied to financial performance standards, it can be very powerful. So the incentive system really needs to be developed by your peers as well. So what we try to do is get physician champions that really believe in what we're trying to do under value-based care and have them kind of help create an incentive system to get their colleagues and peers engaged in this. But I think it's a long journey for a lot of physicians. This really is a whole new world for them. And they've always felt that they provide excellent patient care, but now they're really being asked to look at every aspect, including the patient experience and the cost of that MRI, where do they get that service? So I think they need a lot of assistance from other clinical leaders and really from the business people to help make their lives easier to manage the care.
Yeah, so I mean, it depends on where the physician is coming from, but one of the appeals can be made to their better selves, which is to say, we're really talking about a better care model. So we will have, if you participate in this program, you will have in your practice access to additional resources that just simply don't exist in the fee-for-service world. Things like nurse care managers for really complex patients, pharmacists to assist with both generic substitutions and with managing of higher cost drugs. Things like patient reminder systems to bring the patient into the office, patient education, things like that. So it really provides things to a physician practice that they really don't often have the scale to do on their own. For others, it's, and depending on the market, it's simply a way to preserve the fee-for-service system. In other words, payers in some cases are coming forward and saying, we can't afford to pay you these legacy rates without something else, without you adding some additional value to the system. For physicians who want to have a more active voice in governance, and especially with regard to clinical quality, and looking at populations and making sure that standards of care are applied consistently across the entire continuum. And as Kathy mentioned, of course, incentives are always helpful for everyone, no matter what, from where you're coming at it from. So, it just depends on who the customer is and what their frame of reference is.
Yeah, the key is you've got to find a way to get your physicians engaged. Mm-hmm. Whatever that needs to be, every organization may be different.
Sure.
Great. And so what is the recommended progression to risk?
We may have different viewpoints, but I'll speak and then let Marty speak. I think at Rush Health, we spent a lot of time in the pay-for-performance world. We really started our programs 15, 20 years ago before most of the national payers even had any idea how to measure quality. So I think we wanted to start with easing our doctors in, where we're really focused on clinical quality measures that we know are going to have a direct benefit on our patients. And then we try to move more into limited shared savings where you start absolutely with upside. I think anybody that moves from fee-for-service directly into downside risk is just a recipe for disaster. And we've heard a lot of bad stories locally and around the country where those deals have gone very bad very quickly. So starting with some kind of upside where if you don't hit your targets, you're not going to be penalized, but you certainly have incentives if you do well on both the cost and the quality components. And then I think one thing to start moving down to the progression of risk is have your care coordination fees at risk. If you're able to negotiate care coordination fees to help manage that population, to have care navigators, care coordinators, that could be something at first that, the payers will pay you a PM to manage the population. And then if you don't hit your targets, you owe them back that money. So you're kind of in essence paying back the money the payer gave you. That kind of starts the downside risk. And then gradually move into limited downside risk where you really have appropriate member caps and you have appropriate downside risk caps so that you can ease into it and it's not open-ended that you could lose millions of dollars. I think You have to progress down that line, and eventually the sophisticated systems that have been doing it a long time are willing to take full downside risk or percent of premium, and they truly are managing their population. But the progression's got to be, a year or two at each of these stages before you're at that sophisticated level of managing downside risk. And I know Marty has a lot of experience in this market as well.
Sure. So when we talk about progression, I think of two kinds of progression. One is progression in the number of managed lives or lives that are attributed to you or somehow you're responsible for. And the other is the amount of risk that is taken financially by the organization. And they do kind of correlate, because to get to the maximum numbers of lives, you do have to assume more risk, but it's something that you want to do over time. So when I work with clients who are talking about how do we get started, there's this whole idea of getting to the starting line with a starter set of lives, and that, some of the more easy sets of lives to get to are, as I mentioned earlier, your own employees and beneficiaries of your employee health plan, and then the Medicare Shared Savings Program, although that's pushing people to risk faster than it used to a couple of years ago, but it's still a viable way to get your toe in the water, I guess, if you get started with some lives. And then pursuing the pay for performance opportunities gets processes started of reporting quality data and getting a little upside potential and incentives going without throwing the whole enterprise at risk with downside terms. I don't want to mention specific payer names, but I will say that in Medicare Advantage, several of the major national insurance companies that you all heard of have paths that take on progressive risk, and so they might start with pay for performance, and then they'll have some upside risks, and then gradually build into some downside risk, and then ultimately, if you wanted to go there, full risk. But in the experiences I've had talking with these payers about this, it's not like there's a definite, by year 2, you have to move to this step. It's really kind of working together to see when you get ready for that next stage, and you still have control over it. So that's a very actually enlightened kind of a model. It's nice to know that that's out there.
And so if payers are unwilling to be flexible with the deal terms, what is the bare minimum to accept a deal?
Yeah, that is a good question. I think today we went over only 6 items that we find key, but there's a lot more than those 6 items. I do think there are some payers that have a standard model that is non-negotiable. So if I had to limit it to just a few things before you walk away from the deal, the one thing would be the ability to exit. Get a termination provision that you are not locked in for a 5-year or a 10-year deal. That could be financial suicide for your organization. The other one is if you have to have downside risk, you've got to have a cap on it. You've got to have a member cap, and then you've got to have an overall total cost of care, a maximum loss cap on how much money you could lose under that arrangement. And then the access to data. You cannot be successful. That was why capitation was not successful in the 80s and 90s. Nobody had access to the data. They were trying to manage population of patients without any information on their patients, where they're getting their services. So I wouldn't say one, but I would say all 3 of those. The access to data has to be key to make that actionable for your physician. Marty probably has other ones he would pick as well.
No, I'd go with those as well. Yeah, just
we didn't even talk ahead of time. Look at that.
Great. And then earlier in the presentation, you talked about other types of contracts with provider members and strategic partners. Is there more you can say on that?
That might be a fitting subject for a future webinar, because each of those is kind of a big area of discussion. And in particular, people are doing some really interesting contracting with, for example, skilled nursing facilities, where in exchange for collaboration and data sharing and coordination of transitions of care, they're getting more steerage of referrals to preferred providers. And we could do a whole webinar on that, but it's an exciting area.
Direct to employer contracting is the new exciting area. I would say lots of opportunities if you can get the insurance company out of the middle and work directly with employer groups. Hard to establish those relationships, but where we've had direct relationships with the employers, it really has been very meaningful. You're just a little bit closer to the patient and the healthcare dollar in that scenario.
Great. Well, thank you. That concludes our Q&A portion of the webinar. So again, today our hosts have been Kathy Najarian from Rush Health and Marty Manning from Lumina Health Partners. Their email addresses are here on the slide if you'd like to get in touch with them directly. Again, I'm Lisa Towers, Director of Marketing for Lumina Health Partners. So if you have any questions following the webinar, feel free to get in touch with me. You can learn more about us on our website, luminahp.com. You can also follow us on Twitter at LuminaHP, and also follow our company page on LinkedIn at Lumina Health Partners. And we also have a YouTube channel, youtube.com/Lumina Health Partners, where we will post the recording of this webinar probably sometime next week. We'll also send a follow-up email with the replay of the webinar. So we thank you so much for joining us today. Thank you also to Kathy and Marty for joining us, and we hope to see you on a future webinar. Have a great afternoon.